All right, and good evening, and welcome to Exercise and Complementary Therapies for Inflammatory Arthritis Pain. Tonight, we're going to discuss how physical and occupational therapy, mind-body therapies, and acupuncture can make a big difference for people living with inflammatory arthritis. Our speakers today are Michelle Loy. She is a integrative medicine physician at Weill Cornell Medicine. We have HSS occupational therapist, Daniel Crow, and HSS physical therapist, Michael Goldstein. So thank you so much for joining us tonight. We really appreciate it. And I will hand it over to Michael and Daniel.
Evening, everybody. Excited to discuss this topic with my friends here. So we'll start by kind of breaking down the topic of tonight, which is mainly focusing on rheumatoid and osteoarthritis, kind of narrowing our focus in there. So overall, we'll give a overview of kind of what the process of inflammatory arthritis and kind of how it impacts the joint. So, when we talk about inflammatory arthritis, we talk about some of the parts of the bodies that are affected. Basically, it's a systemic disease, which may and usually does affect multiple parts of the body and joints, can also affect underlying organs, lungs, heart, eyes, and tissues. Kind of the differences more so with osteoarthritis is when we go into more limited to joints and kind of the musculoskeletal. As far as the medical management here, you'll see some of the positive biomarker tests. Patients may show elevation in proteins such as rheumatoid factors, C-reactive protein, and ESRs on blood tests, whereas in osteoarthritis, we'll see these biomarkers will be negative. Some of the causes of inflammatory arthritis, such as rheumatoid arthritis, it's more autoimmune disease related to a body-wide inflammation, whereas osteoarthritis is more mechanical wear and tear on that. When we kind of go into, sorry, I'm having a difficulty with substance. So when we go into these things, while the management medically is different and some of the rehab is different, a lot of similarities and crossover will occur. So we'll kind of touch base on that and kind of walk you through that the way it goes. So we'll start off with going through the physical therapy management of that. So Michael, I'll pose the first question to you. When you have a patient coming into your clinic, what is kind of the walkthrough process that you'll go through, the evaluation, kind of the assessment things? What are some of the things you're looking for? And kind of what are your general recommendations for someone coming in with either, kind of rheumatoid or osteoarthritis?
Yeah, I think, as with any patient, you want to assess their mobility, their flexibility, range of motion. So those are all things that we're looking at. How is this person moving? What's the quality of the movement? Are there compensations in how they're moving? And you want to look at their strength. So we have different tests that we'll do to assess that. Some of it being just resistive strength testing against the therapist's pressure, or some of it is more functional strength testing, where we're going to look at, can they get up and down from a chair? How many times can they do that in a certain time frame? Can they get up and down from a chair and walk a certain distance returning to the chair? So there's a lot of functional tests out there to kind of assess someone's mobility and their strength. And then, in some aspect, we want to look at this is also looking at their aerobic capacity. So that's a huge part in these people. Sometimes they're more at risk for other medical issues, cardiovascular problems. If they're limited by mobility and they're not moving as much, that could certainly impact their overall health. So those are the things we kind of look at. If it's someone who has, an inflammatory arthritis, we're going to do a lot of patient education in terms of managing a flare-up if they do experience one. Sometimes in these patients, they'll have days when they really are in a lot of pain and they're very inflamed and they feel like they can't do anything. And so it's just kind of in those circumstances, you have to still encourage mobility, but kind of make it break it up into shorter bursts of mobility and exercise so that they're not overtaxing their system, because that's the common problem that they often run into in this population. And that's kind of looking at those foundational things: flexibility, strength, endurance, and we kind of tailor our exercises and treatments to address those things.
Great, great. And Dr. Loy, from your perspective, kind of, can you walk through a little bit of in a more of a general sense, why exercise may be important for patients with inflammatory arthritis, and how they can kind of benefit from that from your perspective and experience as well?
Whether a patient has inflammatory arthritis or osteoarthritis, or really pretty much any condition that they come to me for, one of the main lifestyle pillars that we talk about is exercise. And in particular, I will usually recommend a combination of cardiovascular exercise, some resistance exercise, mobility, I call it, and some balance exercises, basically. And I like to call it joyful, mindful movement. So where it is not just for physical health, but also for the mental health. So that is usually what we recommend.
Now, there's including my patients as well, there's a big challenge, I feel like, with a lot of people in coming up with exercises and coming up with cardiovascular or strength-based training type things. So either Michael or Dr. Loy, is there any sort of specific kind of maybe cardiovascular or strength-based type of exercises that you feel are, kind of low impacts, but also give the patient those benefits that we've been discussing?
Yeah, I can jump in on that one. I think one thing with exercise too, especially in patients like this who may be in a lot of pain at times, is it's an exercise that they enjoy doing. If they dread doing a certain thing and you're like telling them to do that exercise, it's a battle you're not really going to win. So it's find something they enjoy doing, one, and then depending on case by case basis, some people will do really well with maybe aquatic exercise. So people like to get in the pool. It's going to be less stress on their joints. They can, the resistance of the water can provide a strengthening benefit. And you can make it aerobic as well by adding walking faster, walking slower, treading water. Any of those things can kind of make it aerobic, and that can be less stressful on someone who's got inflamed joints. Other types of things, some people really enjoy yoga or Tai Chi or any of those things that are emphasizing mobility. And a lot of times some of the limitations in these patients is they feel very stiff. They have a lot of stiffness. They wake up in the morning and they feel their joints are very restricted. So I encourage, movement early and often. Any type of exercise that does that is generally going to be helpful. And at the same time, you want to kind of, in prescribing exercise, you always want to base it on what's the frequency of how they're doing it, what's the intensity of how they're doing it, what's the type of exercise we're targeting, and what's the time in terms of how long are they doing it. Maybe they fatigue very quickly, and it's more beneficial, as we were talking about before, to have shorter bouts. So instead of a 30-minute exercise session, maybe they do 3 10-minute ones throughout the day. That's the kind of sweet spot in this patient population. Is it something they enjoy doing? Is it something that leaves them feeling better after the fact? Or is it something that leaves them feeling worse after the fact? Because you want them, exercise should feel beneficial, should feel helpful for them. If it's something that is increasing pain and increasing inflammation, it's going to decrease their compliance with it, and it's not going to have the benefits that we're looking for. So that's what I look at in prescription for exercise for these people.
Yeah, no, I think you made a really good point. I mean, it's that such delicate balance that we try to find with a lot of our patients, and obviously we each have our own different perspective, but I do find that we all probably keep coming back to this kind of, how can we get these people moving? How can we get them moving effectively? How can we get them, improving motion strength, things like that. And also approaching it kind of systemically, holistically, kind of looking at the entire picture, which I think is super important. So I think you raised really a couple really good points. And from a physical therapy standpoint, kind of, I know it depends based on person to person, and I have my own perspective on this, but what can a patient typically expect when they come to you as the physical therapist? Are they looking at a prolonged rehabilitative program, or is it something more like you're guiding them, you're teaching them how to manage these symptoms, so that way they can kind of use these tactics and use these techniques, kind of for as long as they need them, maybe indefinitely.
Right. Yeah, that's a really important point, I think, to make, because sometimes, when someone's referred to physical therapy, if it's a circumstance where they had a broken ankle or they had a surgery, there's kind of, there's more of a clear endpoint in terms of, okay, I'm the doctor cleared me to do this. I'm back to this. My arm, range of motion is full and my strength is back to what it was. I'm doing back to my daily activities. And someone with more of a condition like this, where it's the end isn't so clear. So it's kind of like, from a physical therapy standpoint, we have to create independence. We have to develop a program that's going to be helpful and allow them to maintain these benefits over a prolonged period of time. And it's not to say that they can't reach out to the physical therapist and touch base with them based on their progress, but it's something where we want to teach them how to do these things to help them feel better, rather than being the person who allows them to feel better through kind of hands-on manual therapy techniques. Those, in these cases, tend to be less effective because the patient will develop a kind of reliance on the therapist. That's a whole other conversation. But the main thing being that we want to teach independence. We want to encourage them to know what to do when they do have flare-ups, when they do have pain, because the idea that there will never be pain is not really a plausible thing for anyone. So I think just preparing them for when things do get aggravated, when there is more pain, when there is more inflammation, what can I do that I know is going to make myself feel better? And that's our goal in physical therapy. And that's kind of how we have the best long-term outcomes with our patients.
Yeah, no, I agree with so many things you said. So, all right, I'll let Michael kind of take over and ask the next few sets of questions as we continue.
All right. So, yeah, in terms of, well, this is a good question for you specifically, Dan, in terms of occupational therapy. A lot of people maybe aren't so sure what's the difference between occupational therapy and physical therapy, and what type of treatments would you do in occupational therapy with these kind of inflammatory arthritis conditions?
For sure, we get that question a lot. When is it appropriate to see an occupational therapist? When is it appropriate to see a physical therapist? And kind of what is the difference? And and to be honest with you, it sort of depends on what kind of environment and what kind of situation that you're in. For us at HSS here with our outpatient rehabilitation, kind of like what you would expect when you go to a rehab facility. Myself and a lot of other of our occupational therapists are actually what we call certified hand therapists, which really just means it's just an extra specialization on rehabilitation and even some orthopedic rehabilitation in the shoulder, elbow, wrist, hand. That kind of is where our specialization focuses. Occupational therapy also tries to incorporate and integrate functional living into the rehabilitative process and actually the end goals. So, we try to take what you're looking to do specifically and roll that into our goals and how we treat to get you back to those specific functional daily things or leisure tasks. So as far as the difference, there is a little bit more of a functional goal, although I feel like our my colleagues in physical therapy do a really good job of doing the same thing, making sure that your goals are being met, and that your functional capacity is being considered when incorporating these exercises. But typically here at HSS, for us, a lot of times if it's something upper extremity wise, you will likely see one of our occupational therapists. If it's something more lower extremity or the back, you will likely see a physical therapist. So that does kind of split it down the middle a little bit there. Now, when we talk about occupational therapy, when we talk about osteo and rheumatoid arthritis conditions in the upper extremity, it's a little bit different. These are, when we talk about the lower extremity, like Michael did, those are very like heavy load bearing joints. So the approach is different. Our upper extremity is used a lot for, accessing our environment, fine motor coordination, reaching, grabbing, lifting, things like that. So the approach is different. I spend a lot of times with my patients about the educational process on what is going on and how we can remedy this. And the way that I word it to a lot of my patients is that, this is no longer when I give you this education, I give you these exercises, I don't want you to think about it as this finite exercise program. It's not something you're going to do, twice a day for a month or two, and then you're never going to have to worry about it ever again. In a lot of cases, these are chronic conditions, osteo and rheumatoid arthritis. These are things that there's been structural changes to the joint. And a lot of times when people end up coming to me, and Michael, maybe to you as well, the disease process has already gone beyond the milds, because when it's mild and our pain comes and goes, we kind of just seem to just put it on the back burner. So a lot of times when people come, it's usually progressed, their pain is fairly consistent, and it's starting to impact their day-to-day life. So I try to reframe it and think of this is not something that you should do for a short period of time. These are ideas, and these are strategies, and these are some exercises that you'll take with you now and in the future to maximize your function and maximize your return. So, I can get into some specifics, but when we talk about conservative management, meaning non-surgical management of, the hand, elbow, things like that. So I'll talk about the hand first. When we talk about conservative management, the most common is CMC arthritis. CMC is a joint in the thumb, kind of where that base is. So a lot of people have pain, inflammation, and difficulty with pinching and grasping. So there's a variety of different exercises. If you go to a therapist, they may have a different perspective. But for me, it's about getting, maintaining mobility, regaining stability. There also is a lot of splinting aspect for this. Splinting is splinting and bracing. So a protective bracing or splinting to help joints be positioned properly, get proper rest is another tactic that we use. And the huge part of it, which Michael, I think you touched on a little bit as well, is the idea of what we call like joint protection and energy conservation, and these various compensatory type strategies with adaptive equipment, such as grippers and jar opening assists, and this is mostly just for the upper extremity. I'm sure Michael can go into lower extremity ones. It's a huge component of how can we salvage your joints? How can we make sure your function is as optimal as it can be? Because when we talk a little bit about the disease process, I mean, there's the wearing down of these surfaces. There is this inflammatory process that's occurring. And what I also impart on my patients is that the disease process is such that not only is the nutrition to the joint being compromised, which is true in both osteo and rheumatoid arthritis, is that the nutrition to the joint is compromised, and therefore the joint has a decreased capacity to deal with the same level of stress. So it's about salvage, it's about maintaining your activity level as best as we can, but also understanding that, and I think, Mike, you talked about this, like if you do too much, if you try to push yourself through this on a consistent basis, theoretically and ultimately, you're doing yourself a disservice. So I mean, we could talk about this for hours on this. This topic is so massive, but just to kind of just get people a little bit prepped, like it's really a comprehensive program in which we try and tackle all these points in a short period of time, usually a few sessions, for conservative management. So I think those are the big highlights.
Yeah, I think you brought up a lot of good points, and I think one thing that's really important and a struggle for some people is the balance. When if I do too much, I'm irritating, but if I don't do anything, I'm not helping myself either. So
Right.
learning that balance for the patient, I think is a challenge, but that's something that's important for us to emphasize. Dr. Loy, if you can tell us a little bit more about like incorporating integrative and different traditional medicine techniques for patients such as these, sleep, nutrition, and different types of behavioral medicine.
So this is actually comes from the National NCCIH, which is the NIH arm that studies complementary integrative medicine. And this is just, I like this chart because it shows how we approach conditions from a comprehensive integrative perspective. So there's the mind and the body. So usually I will, when a patient comes to me with rheumatoid arthritis or osteoarthritis or any type of arthritis or any other condition, we will start with first pillar, which is nutrition, which was mentioned before, food as medicine. I'll usually recommend an anti-inflammatory diet. And then, and that covers a lot. That's a very, we'll talk about different phytochemicals in plant foods that can be very helpful to tamp down the inflammation. And then we may talk about herbs, botanical spices that can be really anti-inflammatory. For example, turmeric, ginger, they act very much, they're basically like a non-steroidal anti-inflammatory, but they act in very much similar kind of way. So we may talk about boswellia, for example, which is frankincense that can be very helpful for joint pain. In some cases, some of the other physicians refer for medical cannabis consultation. So these are all types of nutritional plant type approaches. Then there's the mind-body connection. And many, many patients with arthritis also have things like insomnia, fatigue, pain, obviously pain, depression, anxiety, and all of these comorbidities can be also approached from with some mind-body techniques. So cognitive behavioral therapy, meditation, mind-body stress reduction, hypnosis, guided imagery, breath work. These are all mind-body techniques that we also provide to our patients. And then you can see here acupuncture. So I'm also board certified in acupuncture. I use that all the time for my arthritis patients. They respond very well to acupuncture. And with acupuncture, you can address not just the pain, but also many other symptoms, including anxiety, fatigue, depression, and any other, sometimes people have digestive issues or hormonal issues. These are all things that can be easily addressed at the same time. Of course, exercise, PT, OT, we always refer our patients for that. And on the exercise component, I really just like recommending that patients walk. And if they need a little bit of strength training and they're able to they can just carry, maybe water bottles or light weights with as they walk. Outdoors if possible, because it's all related. So getting light on the retina early in the day really sets our circadian rhythm in a good way and helps with sleep and helps with proper rest. Another exercise, swimming. I'm a big fan of aquatic exercises for arthritis patients. Tai Chi, Qigong, we offer those. Yoga, also very, very helpful. So those are the exercise type. And of course, manual therapies, hot and cold. We will use that. There's even narrative medicine. We have a narrative medicine group, and there actually is a study showing that in those who wrote about their this was asthma patients and rheumatoid arthritis patients, they had reduced symptom reduction in their symptoms when they engage in a narrative medicine or writing, journaling type situation. So these are some of the other approaches that we can use. There's also traditional Chinese medicine and Ayurvedic medicine sometimes we'll use. And these are all, some of the tools in our toolbox that we may use besides or in addition to medication or surgery.
Yeah, I think you brought up so many great points there, about all these different, and I love the way you said it, tools in our tools box, things that we can pull out depending on the patient's needs. And I mean, you touched on so many things, again, that we could speak about hours. I mean, nutrition and sleep and all these things that we're learning, the more we go, how important these things on impacting total health, not even just these things in particular. So I think, patients can see great benefit with having this kind of, overall care with physical, occupational, medical management, acupuncture, nutrition. I mean, all these things, I'm glad we're getting to this point in medicine where we stop like segmenting things. It's not just one part of your body. It's not just one thing. It's usually something that's going on in multiple systems, and there's a multitude of different answers that could be helpful. So I'm really, really glad that you went through a lot of these things, because they're so crucial, and I think in helping patients get better. And I think from a rehab standpoint, I mean, we try to impart some of this knowledge, but to have someone like you and your team who can really get into the specifics and perform some of these things are actually incredibly beneficial. So I think it's really helpful for a lot of these patients to hear about the different options that they have. And of course, there are the medical, pharmaceutical management, things like that, which have a huge role into it. Especially in our rheumatological patients with the advancements in like these DMARDs, the disease modifying, type drugs that have been coming out. But just to touch base on some of these other things, I think it enriches the care so much.
Absolutely. I think it has to be multifactorial. I think the days where it's, I have this is the medication. I mean, I think we're doing people a disservice if with that old model, I think, and it's great, some of the things that we're talking about, and the person has to see, find the right dosage for them. Maybe, that's combining some of the various treatments and making sure that it's specific to them, because not everybody presents exactly the same. But I think it's kind of addressing it from different approaches, using all the tools in the toolbox, as we've said. I think that's the best way and most effective way to help these people. I think we can open it up to some questions. This one is from A. Addy. So in suspected lupus, should you check both ESR and CRP, as ESR might be elevated despite CRP remaining normal? And that is from Dr. Addy. Looks like in England. So, wow. Thanks for joining us. Dr. Loy, this sounds like more of a medical-based question. Would you have any thoughts on that?
I am not a rheumatologist, so, but I mean, I would test for both ESR and CRP. We routinely do that, so I think that.
Yeah, I mean, I'm not a medical doctor, but I would imagine, it's always good to rule out other things, and testing both sounds like the right way to go there. Then we have a question from Elaine. It says, what about if a high functional person who is dealing with psoriatic arthritis as well as fibromyalgia? Well, I think I would answer that and say that, you know, a lot of these foundational principles that we've talked about and the different modalities and treatments that we've mentioned would still hold true and carry over. I think it just maybe if someone's dealing with multiple conditions, does that alter their the balance that they have to find, whether in terms of how much exercise they can tolerate and how much is too much, and how much is not enough. So just kind of finding that balance, but the same foundational things of mobility, strength, endurance would still kind of carry over there. Do you guys have any thoughts on that?
Yeah, no, I think a lot of the things that we touch on apply to a multitude of these different inflammatory arthritic conditions and other rheumatological conditions. I think it's important, depending on where you live. Not everyone lives in in New York City or Long Island and is able to come to HSS. So I think, or New York Presbyterian, Weill Cornell, like to have, we're so lucky to have the robust medical community that we have. But I think the important thing is wherever you are, finding a therapist, a physician, an allied health professional who can find a specific tailored program to your needs. I mean, we give you some suggestions as far as like, general exercise, mobility, things like that. But I think, to get into the specifics, get properly evaluated, get someone who really is going to sit there and tailor a program to what you're looking for and your goals. So for those type of things, that's what I would definitely recommend. Make sure you find someone who's going to take the time and really listen.
Yeah, I would add, we work very, very closely. Actually, most of our referrals are from rheumatologists, HSS, and we work in collaboration, right? And some of these patients are on very heavy DMARDs or different types of cutting edge therapy, and our role is to help support the patient's symptoms so that they can adhere most tightly to the regimen prescribed by their rheumatologist. So, yeah.
Yeah, and that actually answers one of the questions about would my rheumatologist, referred me to occupational therapy. I think, it depends if they found it to be appropriate, but like we've spoken about, I think that's a huge referral source to occupational therapy, and there's a lot of things that can be done in a rehab setting to help those patients.
Yeah, for the OT specific part of that, yeah, I mean, I do think we definitely get, we have a very robust rheumatology department here at HSS. So we definitely work very closely with them. A lot of what we'll do is with rheumatoid arthritis patients, like I talked about, the if it's something in the hand, wrist, which we often see, a lot of what we'll do is try and, prevent deformity as well. Luckily, this is getting less and less with the advancement of the DMARDs, but we still get the deformity. People who are listening with rheumatoid arthritis probably already know what I'm talking about, or at least have heard about things like, the ulnar drift, the fingers going off to the side, various things like boutonniere and swan neck deformity, which are various deformities in the hand. So one of the things that we try to do as best as we can alongside the medical management, which is a massive part of kind of limiting these deformities, is custom splint fabrication, among the things like the compensatory adaptive equipment and strategies. And so yeah, no, we definitely do. It's a huge part of the team, and if it's something that you think you might benefit from, it's a good time to have a conversation with your rheumatologist. I'm sure they would agree, but that's more of a case by case basis based on what they think your needs are.
Yeah, I think those are all really important things to think about and consider with these patients. But here's another question about research, and it's supporting the link between nutrition and arthritis pain. Dr. Lloyd, can you talk to us a little bit about that?
Yeah, there's quite a bit of research on an anti-inflammatory diet and pain and arthritis. And basically, anti-inflammatory diet is really a diet based around whole foods in their unprocessed form, very plant forward, rich in plants, high fiber, low glycemic diet, lots of herbs, botanicals, and spices. And there was actually a randomized controlled trial recently done that I read about on rheumatoid arthritis. I think it was done by the Neil Barnard Hanakaliova group. But again, it seemed like the intervention group did experience significant improvements in their pain and a decrease in the number of swollen joints just after 4 weeks of the plant forward diet. So.
Yeah, so I think that that's a lot of good information. That answers, that question was from Paula. So Paula, yes, research definitely does support the link between nutrition and arthritis pain, and is a helpful tool. And just like we've mentioned, it's something that is a tool, and acting alone, it might provide some benefit, but acting in conjunction with a lot of other treatments, it can be even more beneficial. So I think that's always a very important factor.
Yeah, well said.
And then there is someone who is curious if inflammatory arthritis, and then they also have osteopenia, and would occupational therapy help both of those things? Dan, what do you think?
Yeah, so I mean, there's some research that indicates an exercise routine can help mitigate some of the symptoms with osteopenia. However, there's definitely the medical management that is so important with that as well. But absolutely, I mean, we take all your issues and we attempt to tailor a program that fits the symptoms more so than rheumatoid arthritis, osteopenia, osteoporosis. I think it's important to understand, like, from a rehab standpoint, we're not necessarily changing the underlying disease process. We're more so trying to manage the symptoms and facilitate functional use and return to activity. So yes is the short answer, but from more of a symptom base more so than a disease process base, if that makes sense.
Absolutely. I think that's a key factor to point out. It's not, physical therapy and occupational therapy. We're treating the function more so than we are treating something, medically. I think a lot of medications and a lot of other treatments maybe can be more targeted towards that, but we're kind of in conjunction. That's why it's so important as a team from a medical standpoint to communicate and make sure we're addressing all of the patient's symptoms and impairments. And certainly, we can't, cure a disease process or an inflammatory process, but treating it and allowing that patient to function well and improve their quality of life is kind of our main goal. So I think absolutely we can help in those circumstances. All right, and just maybe one more question. This one is from Mark. Do you guys have an opinion on osteopathic manipulative therapy? And he also mentions physiatrists. One thing. Yeah. Go ahead, Dr. Lloyd.
Oh no, sorry. Go ahead.
I was just going to say, I think those are really great options, especially if a physiatrist is a doctor who's, dealing in functional medicine. How can we get this person to function and improve their mobility, quality of life, all of those things in exploring more non-surgical options. So I think they're a really important practitioner in treatment of these patients. And then in terms of osteopathic manipulative therapy, I think it's another tool in the toolbox, as we've said. But at the same time, I think we want to be cautious in having the patient then become reliant on more hands-on treatment and garnering independence and understanding of self-treatment and being able to manage their symptoms a little bit more independently. Dr. Lloyd, do you have any thoughts?
Yeah. We routinely will refer. We have a DO in our practice who does manipulative therapy that can be very helpful, and definitely physiatry. And I would say, I saw a question somewhere, somebody had fibromyalgia. With fibro, even sometimes even like a trigger point release can be very helpful. And both with the physiatry and with osteopathic manipulative therapy, you're dealing with these sort of muscular trigger points that can be quite helpful for certain types of pain. So even though it's not related directly to the joint, a lot of times there's accompanying pain that can be really quite helpful and help with functionality. So yes, I agree. That's definitely one of the many options in the toolbox.
Absolutely, absolutely. And I think, well, maybe just one more for Dan. Do you find the paraffin wax is something that you recommend? Edie is asking about that. She's curious if that's helpful, how often that should be done. Do you have any thoughts on that?
Yeah, for sure. So modalities, meaning heat and ice and things like this, can be beneficial as far as helping symptoms in the moment. So it does not replace or become a primary, a primary focus of rehab or what I recommend to my patients, but I say it's a management strategy. So again, not going to change the underlying disease process, but helpful as far as mitigating symptoms. So usually what I'll tell people to do, a lot of times people will talk about morning stiffness. Usually first thing in the morning, if you have the time, get in there, heat up your hand, dip the hand in paraffin wax. And for those of you who aren't familiar, paraffin wax is a heated wax that kind of encapsulates the hand. You dip it in, it provides a heating element and kind of hardens on the skin. So it definitely helps with your symptoms. Definitely in the morning I find is helpful. You could really do it as many times as you'd like. I mean, you could overdo anything, but usually definitely in the morning I like. If you're going into if you're seeing a therapist for your hand, a lot of times they'll say, it's good to heat the hand prior to exercises, especially for osteoarthritis. Those stiff type of joints usually respond pretty well to heating elements to loosen and allow the hand to just function a little bit better for a period of time. Inflammatory arthritis, you have to make sure you're just mindful as to heating elements. If you're in an inflammatory phase, sometimes people will discuss that heating can exacerbate this. It just depends on you and your body and how you respond to it. Everyone responds a little bit differently. So yeah, absolutely is the short answer. And, really, as far as frequency, whatever feels good. Once, twice a day, maybe when you need it.
Yep, I think frequency can always be variable from person to person. And I think there is some of a, test retest kind of scenario where, if you kind of learn, oh, well, I did this amount, it felt good. That might be the right amount for me. I did too much of something that was aggravating. Maybe I need to scale it back a little bit. So I think that's an important factor as well.
There's a quick question. I saw someone say, like, talking about joint replacement. I think it's important that we at least discuss that a little bit, although none of us are orthopedic surgeons, just because it's such a huge part of this population. I, for myself, treat a lot of total shoulder, reverse total shoulder, mostly as the largest kind of joint replacements that I see. And from my perspective, obviously there's, you have to discuss this with an orthopedic surgeon. There's a lot of factors. We usually recommend you attempt conservative management. We usually recommend you attempt, altering your habits, altering the way you use your arm or your legs, or, fixing your gait. Mike, you could talk about that if there's a gait issue. But usually, most surgeons and physicians will recommend a trial of conservative management for these things, but they are a huge part of this population, especially in the osteoarthritis population. I get a lot of questions from my patients. When is the right time to do it? How do I know when I need to do it? And I know this is very general, but working with a lot of our surgeons here, usually you'll know when you need it. A lot of these procedures aren't going anywhere. They're there when you need them. there's no real, from my perspective, there's no real benefit of doing it much earlier than a little bit later. My big things are, if your pain is persistent, consistent, and significantly and meaningful impacting your function, these are times to discuss these things with your physician, seek an orthopedic surgeon, and then you kind of weigh the pros and cons, because there are always pros and cons to doing it and always pros and cons to not doing it. So make sure you're properly educated as to those things. But that's usually how I address that when I get those questions, often enough.
Yeah, I think joint replacement is obviously something that we deal a lot with in physical therapy as well. And I think it's like you said, first thing, it's an elective surgery. So when the patient asks me, do I need this or not? It's just like Dan said, is it severely limiting your function? Is it limiting your quality of life? Is it impacting you so much so that you're really restricted in doing certain things? And at the same time, have you tried conservative measures, be it some of the many modalities and other medications or any other types of treatments that we've discussed, and you're still very limited and it doesn't seem to be showing signs of improvement? That's when I would say, okay, well, recommend a surgeon and see, they'll take some images and see if they feel that by doing surgery and restoring a structure of the joint, is that ultimately going to help the person's functional limitations that they're having. Sometimes, the surgeons, they want to be successful in their surgery, right? So I think sometimes people are always like, oh, the surgeon, he's just going to want to do surgery, but they want it to be successful. So I think they'll give you an honest opinion. If you have other things medically going on and they're very problematic and they don't think you'll have a great outcome, I think they'll be candid about that. So, main thing to take home from that is, conservative measures. Once you've exhausted those, once you've kind of seen you're not making progress, but instead you're actually regressing in how you're feeling, that's the time to see the surgeon. And a lot of times they can do things that are very helpful. And even after the fact, the rehab in those cases is just as important. So I think it's always kind of a last resort, but it does play a role in these kind of patients. I think that's all the time we have. I appreciate, everybody listening, and it's been great to be a part of this discussion. I think we got a lot of good insight from Dan and Dr. Loy, and I have learned a lot myself, and it's great to be a part of this.